Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Young Patients with Non-Germinal Center B-Cell-like Diffuse Large B-Cell Lymphoma Benefit from Intensified Chemotherapy with R-ACVBP plus rituximab compared with CHOP plus rituximab. Analysis of data from the Gila-Lisa Phase 3 trial LNH032B by Thierry Jo Molina et al. My name is Ryan Cassidy, and I am an Assistant Professor of Medicine at the University of Washington and an Assistant Member at the Fred Hutchinson Cancer Research Center in Seattle, Washington, USA. My oncologic specialty is hematologic malignancies. Published in 2011, the LNH032B study enrolled 380 patients between 18 and 59 years old with newly diagnosed diffuse large B-cell lymphoma of low intermediate risk, as defined by the Age-Adjusted International Prognostic Index. These patients were then randomized into one of two treatment approaches. The experimental arm consisted of 4 cycles of the intensified regimen rituximab, doxorubicin, cyclophosphamide, Vindicin, bleomycin, and prednisone, or R-ACVBP, followed by 19 weeks of additional consolidation therapy consisting of methotrexate, rituximab, ifosfamide, etoposide, and cytarabine. This was compared to standard R-CHOP every 3 weeks for 8 cycles. Though toxicity was generally greater with the R-ACVBP regimen, it produced significantly longer progression-free and overall survival. To date, this remains the only head-to-head study in diffuse large B-cell lymphoma in the rituximab era where CHOP-based chemotherapy was found to be inferior. Despite these results, in most parts of the world, CHOP has remained the standard chemotherapy backbone for the initial treatment of this disease, thanks in no small part to the fact that Vindicin, a synthetic vinca alkaloid, is not widely available. In this report, Dr. Molina and colleagues performed a post hoc analysis of several biomarkers to determine if a subset of patients could be identified that benefited the most from this intensified regimen. The focus of their attention was on 2 major categories that are highly relevant to DLBCL. One was the cell of origin as defined by the Hans algorithm. This method relies on immunohistochemistry for CD10, BCL6, and MUM1 as a more practical surrogate for gene expression profiling to segregate cases into either germinal center B-cell, abbreviated GCB, or non-GCB subtypes, the latter of which has been shown consistently to have an inferior prognosis. The other biomarker of greatest interest was co-expression of MYC and BCL2 by immunohistochemistry, which, when present, has been associated with a relatively poor prognosis following R-CHOP. Based on the specimens available from which adequate results were obtained, they found that R-ACVBP regimen was superior for patients with non-GCB DLBCL, but no significant differences were observed with any other biomarker tested. The authors concluded that the Hans algorithm may identify a subgroup of younger patients with DLBCL that benefit significantly from this intensified regimen. As the number of prognostic biomarkers for DLBCL expands, our ability to use them to predict outcomes from specific interventions is lacking. The authors are to be commended for attempting to bridge this gap using data from a large, multicenter randomized controlled trial in a relatively straightforward manner. Central laboratory testing was performed with previously validated techniques. Pathology specimens were available from only about 60% of patients enrolled on LNH032B, but the authors stated that this subgroup did not differ from the group as a whole in a variety of parameters. Curiously, they did not observe any prognostic impact of MYC-BCL2 co-expression, an observation that has been described in a number of other series. As the authors point out, this analysis included only 28 such cases, all of whom were younger patients with low intermediate risk, age-adjusted IPI scores. Therefore, the prognostic significance of MYC-BCL2 co-expression in this specific subgroup may not be as important. Another controversial issue on this specific topic is the relative importance of protein expression by immunohistochemistry versus chromosomal translocations at these genetic loci. As the latter was not systematically addressed in this study, such comparisons could not be performed. Given the relatively poor prognosis of non-GCB DLBCL, improvements for patients with this subtype are sorely needed. These data are encouraging that the R-ACVBP regimen may offer such an improvement. The hypothesis provided by the authors regarding how the R-ACVBP regimen overcomes the negative impact of non-GCB DLBCL seems plausible, citing relevant observations from in vitro models. Unfortunately, due to the relatively limited availability of Vindicin, the thought-provoking findings reported here are difficult to directly apply universally. As a response to this, it is tempting to consider replacing Vindicin with a more widely available vinca alkaloid like vincristine or vinblastine. Alternatively, and as the authors pointed out, other dose-intense regimens that incorporate agents like methotrexate and cytarabine in an alternating fashion, such as the R-hyper-CVAD regimen and R-Codox-M R-IVAC, might provide the same sort of activity against the chemo-resistant niche as that proposed by induction with R-ACVBP followed by multi-agent consolidation. That said, these approaches are substantially more toxic and complex than R-CHOP, so any improvements in efficacy will need to be viewed with this in mind. While the data from this report are certainly provocative, it is important to point out that these results came from a secondary analysis and should be validated in an independent prospective fashion before being widely accepted. Dr. Molina and colleagues provided several reasonable examples of how such efforts might be performed in the context of this study's findings. For example, there are ongoing Phase 3 randomized studies testing the addition of newer agents to the R-CHOP backbone to try to exploit certain biologic features of non-GCB DLBCL, including inhibition of the B-cell receptor signaling pathway. If these targeted approaches improve outcomes over R-CHOP alone, then these more intensified regimens like R-ACVBP might represent appropriate comparators to determine which approach is truly superior for this subtype of DLBCL. In conclusion, the intensified R-ACVBP regimen appears to improve outcomes selectively for non-GCB DLBCL based on a secondary analysis of the large randomized LNH032B study that compared this regimen to R-CHOP in young, low-intermediate risk patients. These findings shed some light on a potential avenue of investigation to improve the outcomes of a relatively high-risk subgroup of DLBCL and demonstrate how a prognostic biomarker for this disease might also be predictive of response to treatment. If validated in an independent prospective fashion, such a strategy could lead to a significant shift in practice for one of the most common hematologic malignancies. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.